Welcome back to Breathe Easy, the micro-learning module that takes high-pressure moments of respiratory care and breaks them down one decision at a time. I'm your host, and this is episode 26, part 5 of our iTXA series. Here's the scene. A patient with blood in the airway, holding steady for now, and a call to make about how, and how aggressively, to step in. That's where today's episode lives. This is part 5 of our iTXA series, and we're keeping it case-based and practical. When iTXA earns its place at the bedside and when it doesn't, and how to read the patient right in front of you. We'll walk through 2 calls, a win and a miss, and pull out the judgment that separates them. So grab a coffee, settle in, and let's talk through managing airway bleeding one real-world call at a time. Let's set the table up for part 5. iTXA in the real world. Here's where we're headed today. We'll start with this big idea of when iTXA works and when it doesn't. Then I'll walk you through 2 cases back to back. Case 1, the win, where everything lines up, and case 2, the miss, where it doesn't. Along the way, I'll hand you a key takeaway about thinking of TXA as a bridge, not a destination, plus a critical insight about where these calls really go wrong. And we'll close this episode by tying it all together in a quick summary. Sound good? Let's jump into it. So when does iTXA actually work, and when does it let you down? Here's the honest answer. It comes down to clinical judgment at the bedside. iTXA isn't a button you push and walk away from. It's a strategic move, and it only pays off when you've read the patient first. Before you ever reach for it, you're sizing up the bleeding, the oxygenation, the airway control, and here's the tricky part. 2 patients can look almost identical and need completely different things because of a subtle difference in how they're trending. That's the skill we're building today. The good news, nobody's born with it. You earn it case by case through repetition, reflection, and really paying attention to what's in front of you. Let's start with a win. Picture a stable patient with moderate hemoptysis, their oxygenation is holding, vitals are steady, and they can still protect their own airway. That combination is your green light, your treatment window for iTXA. So the therapist moves early with a nebulized dose, and TXA does its job, helping clots stabilize locally in the airway. This is the idea I want to stick with you. iTXA is a time-buying intervention. It buys you controlled stabilization without rushing straight into intubation or interventional radiology. But buying time only works if you keep watching, so you're reassessing oxygenation, bleeding, and patient comfort the whole way through. And within about 20 to 30 minutes, the bleeding eases. That's your confirmation that the patient selection and the timing were right. This is a template. When you see this picture again, you'll know what to do. So the key takeaways I want you to write down: iTXA is a bridge, not a destination. It can calm the bleeding and stabilize clot formation, but it does not fix why the patient is bleeding in the first place. What gives you is a window of stability to figure out your next move, whether that's imaging, a bronch, or escalating to a higher level of care. And that word bridge is a reminder to stay alert. Even when things look like they're going well, a good early response is not a reason to relax. Loop in your team and make sure the stability turns into a real plan, and keep reassuring. The danger with iTXA isn't the drug, it's the false sense of security. Use it as a bigger piece of the plan, never as the whole plan. Now the harder case, the miss. This is an ICU patient whose hemoptysis is getting worse. Oxygen needs are climbing, and over a few hours, they're clearly declining. And yet, dose after dose of iTXA goes in with no escalation to definitive airway or procedural management. This is a trap. Leaning on one intervention while the clock runs out, the lesson here is about trend recognition. When the symptoms still continue to progress, that's the airway telling you the window for non-invasive measures is closing. That's your cue to shift gears, airway protection, advanced imaging, get a specialist involved. Don't judge the patient on a single snapshot. Watch the trajectory. And honestly, the scariest thing in this case isn't the bleeding, it's the clinical inertia, doing the same thing while the patient gets worse. Catch the failure early and escalate without hesitation. So what's the critical insight tying these 2 cases together? When things go wrong, it's usually not the therapy that failed, it's the judgment around it. iTXA isn't inherently weak. Its success rides entirely on applying to the right patient at the right time. And that shifts the responsibility from the medication to us, the clinician at the bedside. As respiratory therapists, we often are the ones who notice first that the therapy isn't working anymore, and we'll have to be willing to speak up and push for escalation. That takes confidence, situational awareness, and clear communication with the team. So here's my reframe for you. A miss isn't a verdict on you. It's a teacher. Reflect on it, own it, and let it sharpen your judgment for the next patient. That's how we keep getting better. Let's land this one. If you take nothing else away, take away these 3 things. 1, patient selection. iTXA is for stable patients who meet the criteria. Full stop. 2, timely reassessment. Once it's in, keep watching. Are they getting better or worse? Don't let an ineffective therapy drag on. And 3, early escalation. Escalating isn't admitting defeat, it's protecting your patient. No stigma attached. Underneath all of this is real skill, pattern recognition and clinical vigilance, and proactive decision making. Weave those into your daily practice and you'll manage airway bleeding more confidently with better outcomes. And keep your patients breathing easy. This is part 5 of our series in the books, and thanks for listening to Breathe Easy. Take a deep breath and I'll catch you on the next one.